my name is Chloe, and I am now officially a 4th semester nursing student, and I work as an LPN at a SNF right now. And today I wanted to go over EKGs. So a little bit of preface, a little bit of background. When I was studying for my PN NCLEX, I was like freaking out. I was literally like so stressed out about EKGs, and I looked up so many videos about them, and thankfully I did, because I got like 5 questions about EKGs, and I got them all wrong, of course. But if I had something like this study guide to like help with that, I would have gotten all of them right. And so normally I will post like the study guide on my Google Drive for y'all to download and print off and write notes on and take whatever. But for this one, I have posted it on my Etsy, $3, but I put in like 20 to 25 hours of work on this, and it is so important to my Etsy to buy. And again, it's only like $3, and it's super helpful. I literally wish I had this at the beginning of nursing school, and I wish I would have taken it to my clinicals. I wish I would have practiced more EKG stuff before my PN. But let's just go over it and we'll get it done. So alrighty, let's talk about the oh geez, it's like shining. Okay, so first let's talk about sinus bradycardia. So normal sinus has a P wave, a QRS complex, and a T wave. So that's normal sinus. But let's talk about sinus bradycardia. So the defining characteristics are it has P wave, QRS complex, and T waves. But it's super slow. The patient's heart rate will be below 60 beats per minute, and the normal heart rate is 70 to 100 beats per minute. What the patient is going to feel like the physical manifestations of sinus bradycardia are, they're sometimes going to be asymptomatic, especially athletes, because they have a lower intrinsic rate, which is like the rate that your heart is set at. But sometimes they'll have changes in LOC, so like changes in level of consciousness, and they'll have dizziness, shortness of breath, and chest pain, the usual suspects. And the treatments are, if they're asymptomatic, you literally do nothing, you just monitor them. If they are symptomatic, you stimulate them, so like pain stimulation, trying to shake them awake, hey, get up. Give them oxygen, check their vital signs, especially the blood pressure, and remember their baseline. Call a rapid response, give atropine. Atropine increases heart rates, and then figure out the why. Are they on too much digoxin? Did they have an MI? Maybe an external pacemaker might be indicated for them. And is this a new onset, or have they had this problem before? And that's sinus bradycardia. Sinus tachycardia. So the defining characteristics of that are the same as sinus, normal sinus. So they're going to have a P wave, a QRS complex, and a T wave. The heart rate is going to be above 100 beats per minute. And remember, the normal limit, like the within normal limits, is 70 to 100. And then tachycardia is usually gradual and has 3 distinct waves, and is always a secondary symptom. Physical manifestations of sinus tach are the patient might be anxious. They are going to have a fast heartbeat, duh. And then the usual suspects, and then one more important one is syncope, which is basically fainting. The treatment for sinus tach is find out the underlying issue. The only way to truly treat it is to figure out what the real problem is, and then get rid of the real problem. And here are some reasons why they might be tachycardic. Hypovolemia, which is low fluid volume in the blood, sepsis, anxiety, pain, exertion, and an upper OD. So like an upper overdose, basically like an Adderall overdose, that kind of thing. And look for P's on T's, because that is really dangerous. Look for P waves on T waves with sinus tach. Okay, let's go over atrial fibrillation. So, if you watch my COPD video, you know that it's pretty common in COPDers. Honestly, like, it's the people that are gonna come in with AFib usually have COPD. Alrighty, the defining characteristics of AFib are tiny irregular fibrillations in between QRS complexes. They don't have P waves, and there's sometimes no atrial activity can be identified sometimes. They're just like bing, 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 bing. QRS complex are irregularly irregular, meaning that the R to R intervals vary. So that big pointy R varies between like each other, basically. And let's talk about AFib with RVR. So AFib with RVR is atrial fibrillation with a rapid ventricular response. So that means that their ventricular response is going to be elevated. So they aren't going to have like a normal heart rate. They're going to have like a high heart rate. And that's pretty dangerous. That's dangerous. Physical manifestations, they're going to have a fast heart rate or palpitations. The usual suspects, so chest pain, shortness of breath, blah, blah, blah. Upon palpation, patients' peripheral pulses will vary in amplitude and rate. So they're gonna like vary between how strong they are and how fast they are. And there's gonna be a drop in blood pressure, and they could even get blood clots. They're at a high risk for a PE or a stroke. And the blood clots are related to a lack of atrial contraction. So that blood is just staying in there and it's getting sedentary and it's all just sticking together. Treatments for AFib. Vagal maneuver. So you have them bear down, you have them cough, you have them vagal themselves down. And it might be indicated to cardiovert the patient back into sinus rhythm. And cardioversion is small controlled shocks that push the patient into asystole, and then they hope that the sinus node takes over and then puts them back into sinus rhythm. And you always cardiovert on the R, and it's going to be a nice planned procedure rather than like in a code situation where you're like, let's get this patient shocked. They're going to plan it out, it's going to be scheduled, they're going to come in, you're going to shock them, like all that good stuff. Beta blockers are also treatment for AFib. And the way that I remember that is by beta fish are so funny. It's almost like they lower my heart rate and my blood pressure to remember what beta blockers do. Calcium channel blockers are also going to be a treatment for AFib. And about cardioversion, sorry, I just saw my notes on this. In the beginning, we can cardioverse them, but they might just be a chronic AFibber and they might just go back to AFib. So we got to make sure that we are monitoring that as well. And how I remember calcium channel blockers is that being around pine trees blocks my calcium and relaxes my heart rate and blood pressure because I'm so relaxed around pine trees. And that's the end of the drug is pine. But Cardizem is a brand name that I didn't know about. So Cardizem is a calcium channel blocker. And then anticoagulants are going to be the first line of defense with AFibbers. So like aspirin, heparin, Coumadin, warfarin, Lovenox, all the hits, all the big ones, all the good ones. And then amiodarone and digoxin are going to be used to correct the abnormal rhythm. Let's go over atrial flutter. So the defining characteristics of this are they are going to be regular, irregular, and they're going to have no P's. So it's going to be a skinny normal QRS, regular R to R intervals, but they're going to be like the ventricles are going to be at 70 to 150, and the atria are going to be at 250 to 400. That's going to be the rate for those. And the atria don't take a break, they just march right on out on schedule. So sometimes you'll see like waves on top of waves, basically. And it's gonna look like a sawtooth. Like, you know how a saw looks? It's literally gonna be like that. The physical manifestations, the usual suspects, and lightheadedness, syncope, and fluid retention, with atrial flutter related to heart failure. That's going to retain fluid in their bodies, and they're going to have that whole edema, all the stuff. Treatments, it's going to be like same-ish as AFib. So it's going to be vagal maneuver, cardioversion if they're unstable, catheter ablation. So this is literally a procedure where they cut into your heart to create scar tissue, so abnormal conduction pathways are interrupted. So they literally go in through you and cut out a piece of your heart so that the conduction pathways are interrupted. Beta blockers, LOL, beta fish are so funny. Calcium channel blockers, being around pine trees lowers my heart rate and blood pressure. Anticoags, antiarrhythmias, that's amiodarone and digoxin. And amiodarone is preferred over digoxin because digoxin is toxic over 2, and it takes time to build up a level of digoxin. And so you have to count the QRSs and the waves, because there's no P waves or T waves, it's literally just waves. So you have to like figure out what the ratio is, and that's like, you just have to figure it out. All you do is count it, literally, that's it. But you have to figure it out still. And document it, duh. Alrighty, let's go over first degree AV blocks. So a first degree AV block happens when the sinus node fires and the AV node waits to hold on to electricity, and it holds it, and it holds it, and it holds it, and it holds it, and it finally lets it go. So the sinus node fires, the AV node is like, okay, I have this, and I just want to keep it, I just want to keep it so bad, I just want to keep it, and then it lets it go. So there's going to be a long PR interval, and it's going to be greater than 0.20, like the little squares, and all the intervals are going to be the same. The P's never drop a QRS, and the QRS is always going to be on time. And if the P's are on the T's, remember I mentioned that a little bit earlier, if the P waves are on the T waves, they are, and there's a fast rhythm, they are at risk for V Fib. They're at risk for going into V Fib, and that's dangerous. We'll go over that too. Physical manifestations of a first degree sinus AV block. Most of the time the patients are going to be asymptomatic, and they probably won't even know that they have a block, and they've probably had it their whole life. And the usual suspects will be long if the PR interval is greater than 30, greater than 0.03, due to a lack of atrial kick. And it can also be a side effect of braiding down, like if they were in sinus tach and we gave them too much digoxin and they're like going down. Treatments are for the first degree AV block are monitoring the patient, so get a 12 lead, get vital signs, and call the doctor if it's a new onset. And then external pacing initially, and then permanent pacing if the patient is symptomatic. Again, if they're not, then we're just probably going to ignore it. Not ignore it, but if it's not a new onset and it's chronic, then we probably won't do much. Second degree AV block type 1, this is going to be winky block. And how I remember this is it's longer drop, longer winky block. So, let's talk about it. The defining characteristics of this rhythm on an EKG are there's going to be one lonely little P wave that gets almost all of the beats to the ventricles, and there's going to be one lonely P per cycle, so there's not going to be multiple lonely little baby P's. And the AV node starts to get sleepy. It's just like, oh, I don't want to work, I'm being lazy, I just want to hold on, and then it doesn't get to the ventricles. And the PRs grow longer and longer apart, so that's why it's longer, drop a QRS, longer, winky block. Physical manifestations of this are the patient might be asymptomatic. And then if the patient is symptomatic, the usual suspects are involved, and the patient can be nauseated as well. Treatments for this one are monitoring the patient, treat the underlying condition, as Winky-Bach can be a secondary. So for Winky-Bach, you want to measure the PR interval before the drop and right after the drop as well, to see like what it measures as basically. Then let's go over the second degree AV block. That's going to be a type 2 AV block, and I'm like 99% sure it's called Mobitz 2. So Mobitz 2, y'all. And this is like getting into the ventricles, and this is getting dangerous for the patient because you do not want to have a ventricular block. You just don't. The defining characteristics of this one are like there is a pattern. It's going to have equal PR intervals, but there's going to be extra P's. Physical manifestations, the usual suspects, nausea, lightheadedness, fainting, and the physical assessment might reveal bradycardia. Treatment, if they're asymptomatic, make sure they're somewhere that they can be paced if it's indicated. Pacing the patient, and an internal on-demand pacemaker. So that's going to be a pacemaker that is activated when the spaces between the P waves become too long. And they always have to be paced if they're asymptomatic. They always have to be paced. Nothing but P's on the EKG is you're screwed, basically. You're screwed. There we go. Let's go over a third degree block. So it's usually going to be related to an MI or a valve trauma type of thing, so blown valve. And it can be with a ventricular or junctional escape, and it's going to be no impulses get through from top to bottom. So there's going to be bizarre wide QRSs related to the QRS having its own pacemaker and not following the sinus node. There's going to be some backup ventricular beats or junctional beats depending on where the escape rhythm is coming from. Damage above the AV node is gonna, so junctional beats are gonna be from damage above the AV node, so like a gunshot, a stab wound to the heart, like all that good stuff. The P waves and the QRSs are not on the same page. They are not communicating. They are just going at their own pace, and they're just going, man. Like, they're not communicating. There's no impulses getting through top to bottom, like nothing. So the physical manifestations of this one are the usual suspects, and then fainting, fatigue, and dizziness. And the atrias will probably have a range from 60 to 100 beats per minute, and the ventricles will have about 40 to 40 beats per minute. Like, that's, the QRSs will probably be at 40, and the junctionals are going to be at 4 to 60. And what a junctional rhythm looks like is it's going to be a normal QRS, but it's still going to not talk to the P's, and there's going to be weird bumps on it, and they're going to have different PR intervals as well. The treatment is compressions on an unstable patient, and they might have a pulse, but it's not going to be life-sustaining. You need to get them to a place that they can have a life-sustaining pulse, and you are always going to pace a third degree heart rhythm, literally no matter what. Like, you are going to pace them. Let's talk about SVT now. So, let's go over it. Defining characteristics of SVT are going to be an entire line of PACs, which is premature atrial contractions. That's what it is. And an ectopic cell takes over and acts like the sinus node. It's literally like, okay guys, I'm in charge, like I'm the best, like I'm doing it, like y'all don't know, like I'm literally doing it, like whatever. I don't care what you say, I'm in charge now. So it's gonna look like a skinny QRS, one lump, a skinny QRS, one lump. That's literally what it's gonna be. And it's gonna be paroxysmal, meaning it starts and ends very suddenly without warning. And it's gonna have a high rate above sinus tach. So it's going to be like above 80 to 200 beats per minute. And the physical manifestations are change in LOC, crushing chest pain, shortness of breath, syncope, and the systolic BP is going to be in the 70s. So treatment on an unstable patient is call rapid and cardiovert, always cardiovert on the R. And for a stable patient, you're gonna try to vagal them down. You're gonna try to cough or bear down. And a good cough increases intrathoracic pressure, which helps the heart like chill out for a minute. And then there's a special little drug called adenosine, and this is an SVT breaker. And during a code situation, you will give 6 milligrams of adenosine, then 12 again. And it knocks them into asystole, and the sinus node will take over. Not to get confused with atropine. Adenosine and atropine are two different things. And you have to give adenosine super fast. And it's gonna be a rapid IV push, and it also has a short half-life. And then the third treatment is cardioversion. Now let's talk about V-Tac, the big V-Tac, ventricular tachycardia. This is gonna be nothing but preventricular contractions. And it's an ectopic rhythm. So one of the little ectopic cells in the heart, in the ventricles, is like, guys, I'm taking over, I'm the boss now, there's no sinus node, it's all me, like I'm the one. And it's going to be only wide, bizarre, and fast QRSs. It's literally gonna be like bum, 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 and like super weird and funky. And it's gonna be, the rate is gonna be about 150, so a little bit lower than SVT. 200 is like a super fast V-Tac. Because remember, this is an ectopic cell. It's literally like, it's not gonna be as fast as the sinus node. Physical manifestations, there's gonna be no atrial kick and very low stroke volume. So the usual suspects are gonna be involved. And they might have signs of diminished perfusion because blood flow isn't getting through the whole body. So the treatment depends on the patient as well. So if they are pulseless and unstable, basically if they're looking dead, then you check the patient, check for a pulse, call a code, chest compressions, and defibrillate V-Tac. So you defibrillate them. If they just have pulse and chest pain and like a change in LOC, you get help. You feel for a pulse and keep feeling it. Get them on oxygen, get the crash cart, and cardiovert the patient. You could potentially send them into V Fib if you defibrillate them. So defibrillation is like cardioversion, but it's just like, here we go, whatever. I'm just doing it just to do it, so it doesn't have to be on the R. If they're stable, alert, and oriented ×4 with pretty good vital signs, then we're gonna cardiovert, and it's controlled, and you get the patient's consent. You're gonna give them amiodarone, do a bolus and then a drip of amiodarone. Vagal and adenosine, just in case it's fake V-Tac and it's actually SVT. But, so like that's gonna be like a very stable patient, and it's gonna be SVT with wide QRSs. And hey guys, it is a completely different day, and I also have new hair, so there we go. So we were last on V Fib, so that's ventricular fibrillation, and it stems from multiple ventricular ectopic foci. So those are the cells that are going crazy and trying to take over the sinus node. The defining characteristics of V Fib is a squiggly weird line. It looks like a squiggly weird line. An artifact can mimic V Fib, but literally no one is awake in V Fib. That's not a life-sustaining rhythm. And it's always an emergency, so treat it as such, even if it's just artifact, because you don't know. Physical manifestations, no pulse, no contractions, and no consciousness. No cardiac output, and no stroke volume as well. The treatment, it's always a code immediately, and start chest compressions now. You defib, V Fib, You do chest compressions for super flat V Fib that almost looks like asystole. And you do epinephrine, and that brings blood back to the sinus node. And then there's an ACLS algorithm of shocks and epi too. Okay, great. There we go. We finished. Okay, let's go with Idioventricular Rhythm, IVR, and it's also called ventricular escape rhythm as well. So it's related to a massive MI. So this is what happens when you have a huge MI. The sinus node fails, and the AV node fails, and there's no electricity happening. So one of the ventricular cells is like, I'll start a beat, let's do it. I'll be the sinus node. So it's coming from the ventricles, and it's slow. There are going to be no P's because the atrias are not involved. The ectopic cell on a conductive branch in the ventricle. That's where it is. So it's on a conductive branch inside your ventricle, and it's just taken over. Physical manifestations, what the patient will be feeling: syncope, fainting, dizziness, change in LOC, and fatigue. The treatments are a pacemaker, and they'll probably have to get a permanent one since it is related to an MI. And it's the very last, like, fail-safe. It's like the Hail Mary of your conduction system. And it's just every node fails, and then your ventricle takes over. Okay, let's go over PVCs, premature ventricular contractions. It is related to ectopy. And ectopy is caused by low oxygen, fluid and electrolyte imbalance, and stretch too. Defining characteristics, the QRS is going to be greater than 0.12. It's going to be wide and bizarre with notches and T's in the opposite direction. So instead of like this, they're going to be like this. Aventricular ectopic beat is caused by low oxygen on a ventricular cell, especially a left ventricular cell, and it has to jump in early. It's like, I have to go. It's like, I have to go. Physical manifestations of PVCs is a fluttering heartbeat, pounding, and increased awareness of your heartbeat. Treatments: treat the underlying condition, beta blockers, and calcium channel blockers. Asystole, let's go over this one. So the defining characteristics of this are a flat line, like just physical manifestations, no pulse, and the patient is probably gonna act dead, so they're probably just gonna be The treatments are atropine, epi, and CPR. And then you wait until you can get into a shockable rhythm, and then you can shock them. But you can't shock asystole because nothing's working, so why would you do that? Well, guys, that's all I have for EKGs. Let me know if you have any questions or anything, and get the study guide because it's literally like my Bible. Like, I literally use it all the time. And if I would have had this like before my freaking PN NCLEX, I would have done so much better, and I would have felt a lot more confident than I felt when I took it. So, hope y'all have a great day.